this might be a difficult question, but what do you think high income services, the American, the London, Australian, everywhere else, those services can learn from Africa or from South Africa? I'm happy for anybody to respond, anybody to answer. I know you're all thinking about that, but
Yeah,
anybody would like to venture a point?
let
I
me give
think
it a
Malusi
crack.
and Elias would be better for this.
Well-resourced ambulance services are under pressure. Ramping, overloaded call centres, patients using emergency services as a GP substitute. The instinct is to look inward. But what if part of the answer is already operating somewhere else? In part 2 of our 3-part podcast featuring African paramedics, our guests, Elias Thomas, Malusi Metwa, and Thaluni Sabanda, turn the question around. What can wealthy EMS systems learn from Africa? Their answers are specific and thought-provoking.
Ambulance service has sort of changed from being emergency medical services. It's more paramedicine, more of a support system for the community, not necessarily for just emergencies. There are times where we should just assist the community in many ways, but sometimes I do think that the ambulance is abused by the communities. In South Africa, I think most people normally say it's called emergency medical services, and they treat it as something that you call if there is an emergency. In South Africa, that is what you find, and you normally, most of the time, you really find real emergencies. I think there's a couple of times where I arrive in a person's house and I have to look for a remote under a recliner. I think the sieving of the calls, ensuring that the calls that the ambulance service receives are real calls for people that really need an ambulance. I think, and that would actually assist with the issues like the ramping issues that are like a pandemic in most cities in Australia. There's a law that can be learned in that, and do that at the same time, not reducing the quality of care that is given to everyone. And people must not be afraid of calling an ambulance, but at the same time, people must know when to call an ambulance and when not to call an ambulance. Cases that are legitimately a need for healthcare services outside of hospital, and it mustn't be because my carer did not come today, I'm just calling you guys to come and check on me, It mustn't be those cases. But at the same time, and there mustn't be dependency of the communities to just have an ambulance that is going to come around if there is really no need for medical emergencies. In general, people here, they call an ambulance if there's a real emergencies. I'm here because I'm currently in South Africa now. And I think that can be a great lesson that can be learned from such services.
In Africa, it seems to me that the ambulance is actually relied on for emergencies rather than being more of a primary care service.
Yeah,
Would that
I
be
think
right,
it's
Elias?
more of a case where most people don't know what an ambulance is in actual fact, because, if they have a flu or a cough or so, they'll just transport themselves to the hospital or to the nearest, clinic. And it will normally be in a case where someone can't breathe, where they, most of the time start panicking because they need to find someone to call or like someone to help and come out immediately. And I think most of the times they'll call the fire service first, because like for instance in my country, in Namibia, the fire service is attached to the ambulance service, so they'll mostly call the fire service first, and then they'll come out with an ambulance. So I think that's the time that they will mostly have contact with the ambulance, as compared to other parts of the world. You can call an ambulance because you had food poisoning. You can call an ambulance because you're not feeling like you're 100% this morning, and you don't really want to go out to work, and you don't really want to stick into the queue in A&E, and you kind of want to get seen faster. I don't know who told them they'll get seen faster, but they tend to call an ambulance for that. So I think that's a very difference in the two systems.
What is the answer for the Western service and people just using the ambulance as a GP service in Australia and everywhere else? What do you think the answer is?
The things that happening in your high-income countries is that we had a guest, Amy Hark. I forgot her surname now. I think Amy Hark, and she's currently working in the UK. And one of the things that she highlighted is that, if I remember correctly, I can't say it word for word, is that she's working for an institution, but each city in the UK has different types of training, and each city has different scopes of practice and how they practice. My understanding from what we took from that conversation that we had is that there is no standardization of the training across the whole country in the UK. So each city has got its own. Whereas coming from where I'm currently in South Africa, South Africa is used to have a system whereby each province had its own training, its different scope of practice. But that was not beneficial. Whereas if everything is nationalized, where the same scope of practice exists from one place to another, we have different same levels of care throughout the country, even though there's different levels of care like BLS, ALS, and ILS, even advanced life support. But that's across nationally, not having one province doing certain procedures and the other one doing different province skills. And from that aspect, I think that's something that the higher income countries could learn from African countries, is that the standardization of their training, and that maybe can have a significant impact, especially for their practitioners as well. I can imagine if I was a practitioner that I've learned these skills, now I can take the skills and the knowledge to another place that I want to go work at. How that would be a difficult challenge. So there's something that could be learned. With everything that we do, I think we need to also base our treatment on research, what are the type of cases that are we dealing with? And then from there, you try and differentiate what are those cases that you're dealing with. And then you look at what are the EMS system frameworks that exist. Is it community paramedicine? Is it palliative care? Is it EMS? Or what is it? And all of that is based on what the community need. And we need to understand that one EMS system cannot be used in another EMS systems because we are different countries that exist. So in essence, I think one of the things that can be a solution is that do research. What are the needs? What are the community needs? What the country is currently facing, and then from there try and develop systems based on what exists to improve the service. I hope that makes sense.
It makes absolute sense. It's knowing your customer base or client base and what their needs are, and then providing a service to meet those needs is what
And I think, I mean, just to add to that as well, I think what Tulani is saying, I think we are seeing, like when I started off in London, we got more mental health based calls. And what they started doing is that they started coming up with a mental health car, putting more nurses out, making sure that people are left at home and people don't have to come into A&E or ED, as you may call it. And I think it's really looking at what does the community need and how can you meet those needs at home instead of ending up ramping, or because I also feel that the triage system just captures everything, because the first question that you get asked is, are you breathing? And someone might not understand that. And because they're unable to answer that, the call kind of comes as either sort of like priority 1 or priority 2, which kind of ends up getting an ambulance either way. And now I feel like if we can then sort of try and figure that system out, I think I feel like it will reduce the burden on the EMS system as a whole and the whole sort of like the healthcare system and I would like to speak for London now. In New Zealand, we don't really have the ramping system. I think it's at least in Bay of Plenty, the part of the world which I worked. It was quite, you get to A&E and you hand over a patient in like 15 minutes or so.
When you look at the World Health Organization EMS system, is that it's good as a framework that can be used to start an EMS service, right? However, I think with the developing needs of the community, with things like community paramedicine, which we've spoken extensively on the Para podcast with some of the episodes that we've recorded, but also we've done an episode about palliative care. When these systems are evolving, the EMS systems also need to keep up with that, to meet the community needs. So in addition to the research, is that the EMS needs to be adaptable and keep up with the needs of the community, depending on whichever country that you're in and the community needs.
You just can't take the Bay of Plenty St John ambulance system and plonk it into a similar sized place in Africa and say, problem solved, this will work, it works in the Bay of Plenty, why wouldn't it work in Africa?
Malusi, do you want to go first? Or?
I think it's